Well, hello and good evening, and welcome to this first joint webinar hosted by NAPS and Hormone Health. My name is Nick Panay. I'm chair of NAPS and a consultant gynecologist at Queen Charlotte's and Chelsea and Westminster Hospitals. It's a great pleasure to be with you this evening and to share some information and experiences of PMS and PMDD to improve awareness of this condition to all concerned. And I think we've been totally overwhelmed with the number of questions that we've had. We're going to try and address as many of those as possible, but we're also planning subsequent webinars where perhaps we can address even more of those. I think the need for this webinar and to improve awareness was crystallized by one of our delegates who said, "Many thanks and very much looking forward to the webinar. I had no idea there was a support group." There very much is, and we hope that you will find it helpful. Now, before we launch into the webinar proper, what I'd like to do is talk a little bit about definitions, just in the next couple of slides, because I think there's been quite a lot of confusion, perhaps, between PMS and PMDD. Essentially, PMDD is a severe form of PMS, and we categorize PMS being mild, moderate, or severe. And in fact, NAPS changed its name to the National Association for Premenstrual Syndromes from syndrome to reflect the variation in definitions and severities of this disorder. But we believe that the current PMS terminology should be maintained because PMDD refers to only one type of severe form of PMS, as dictated by the American Psychiatric Association's definitions. And the real key issue, I think, is the education of the public and healthcare providers about cycle-related disorders. And we believe at NAPS that it's vital that there is universal recognition of the severe impact that PMS and PMDD can have, whatever the terminology that is used. Professor Sean O'Brien brought together a consensus group called the International Society for Premenstrual Disorders. And I was part of this group. We published a number of papers, and we reached a consensus on definition, which I think is one of the best around, where we have the core premenstrual disorders, which is classic PMS with ovulatory cycles, functional impairment, and postmenstrual resolution. And then there are the variants, such as premenstrual exacerbation of background symptomatology, like epilepsy, migraine, arthritis, and also psychopathology as well. Then there are the non-ovulatory premenstrual disorders, such as those which occur in women with polycystic ovarian syndrome. There are the progestogen-induced premenstrual disorders, where the progestogens in the pill or hormone therapy induce PMS-type side effects. And then there are the premenstrual disorders without menstruation, such as those women who have hysterectomy, but the ovaries are maintained and so cycle-related symptoms persist, and those women who've had the lining of the womb ablated, so they're not menstruating, but they can still get cycle-related symptoms. So moving on to the webinar, and I'm delighted to share the stage with two of my dear colleagues and trustees from NAPS, and you will hear presentations from Dr. Carolyn Sadler, who is a retired GP and trustee of NAPS, and she will kick off with what to expect from your GP. I will then follow on with what to expect from your specialist consultant. And then Emily Elson, who is an occupational therapy support worker and recent trustee of NAPS, will give a personal account of living with PMDD. And I think you'll find her report very compelling. But with that, what I'd like to do is stop sharing my slides and invite Dr. Carrie Sadler to share her slides, and to kick off with her presentation on what to expect from your GP.
Okay, good evening, everyone, and thank you very much for joining us. Can you see my slides? Yep, okie dokie. So as Nick said, welcome everyone, and my name's Carrie Sadler. I'm a recently retired GP, still doing some work for the NHS. So throughout my career, I have had an interest in women's and sexual health. And I've been a trustee of NAPS since 2003. So I'm going to go through how we make a diagnosis and how we assess individuals in the primary care setting. I'll then go on to describe initial approaches to management and then finish with signposting, how we signpost to other services. So the most useful tool to aid diagnosis is tracking of symptoms. And what I mean by this is the daily recording of the frequency, severity, and range of symptoms over at least 2 menstrual cycles. And if a woman is having irregular bleeding or no periods, then we suggest recording symptoms for an interval of about 8 weeks, obviously recording when bleeding occurs. The daily record of severity of problems is a very well-tested menstrual diary, which can be downloaded. And also now we have a number of different apps in which an electronic recording can be made. It's extremely useful when you go along to the GP to have this information to hand. It can really help the GP to clarify the diagnosis and help with initial management. So the typical pattern for symptoms of premenstrual syndromes is for the symptoms to start in the days leading up to the period and to resolve or significantly improve by the end of the bleeding. As I've said, tracking of symptoms will bring to light the cyclical nature of what's happening. Tracking of symptoms isn't only useful for diagnosis, though. It's also a useful tool to monitor treatment. And again, not only useful in seeing whether seeing improvement in symptoms with different treatments, but it can also highlight if a woman actually gets a worsening of some symptoms with prescribed hormones. For example, some women can actually feel worse if they're prescribed certain hormones, for example, a hormone called progestogen. And this is found in some HRT preparations and hormonal contraceptives. So more than 200 different symptoms have been described as part of premenstrual syndromes. And they can be both physical, so for example, bloatedness, headaches, or psychological, depression, irritability. During the consultation, it helps the clinician that you're seeing to actually just concentrate on the main symptoms of concern and of the greatest severity. And there's no specific blood test which will help with the diagnosis. However, the GP may request certain tests, really with the view to excluding other medical conditions which may be contributing or causing some of the symptoms. For example, if tiredness is a predominant feature, then the GP would want to exclude anemia and thyroid disorders. If joint pains is a common feature cyclically, then the GP may well consider organising investigations to exclude arthritis. What is also really important to discuss during the consultation is how the symptoms are impacting on the individual's quality of life. How is it affecting relationships at work and at home? A management plan should include exploring the person's lifestyle and seeing the ways in which that could be improved. And it also needs to take into account the person's other medical conditions, current medication, contraceptive needs, and desire for pregnancy. And often the management plan can be tailored to actually help more than one particular presentation. For example, a hormone coil is sometimes used as part of a treatment regime in premenstrual disorders, and that is also really useful to help heavy periods and can provide excellent contraception as well. What I'd just like to say at this point, if symptoms are very severe at initial presentation, for example, if a person expresses suicidal ideas, intention, then that would warrant urgent escalation and referral through to the local mental health team, community mental health team. So just saying a little bit more about diet. So very important to try and aim for a healthy diet. And this slide just summarises some of the key features of a healthy diet, which are really applicable to everybody. Working towards a balanced diet will not only reduce the risk of a number of different medical conditions, but can also or will provide the necessary nutrients, minerals, and vitamins that a person needs. But just focusing on specific recommendations in diet for individuals who are suffering with a premenstrual disorder, one of the most important things is to try and work towards stabilising blood sugars. We know that changes in blood sugars, fluctuations in blood sugars, can actually exacerbate some symptoms. So there are two ways in which you can achieve this. One, by avoiding long periods in between meals and snacks. And secondly, by encouraging the person to increase the amount of foods with a low glycemic load. These are foods that cause your blood sugar to rise and fall slowly, so you don't get those quick fluctuations, and help you feel fuller for longer. So what I've done here is just listed some of the some examples of foods with a low glycemic load. It's also sensible to avoid or moderate alcohol intake. Alcohol can in itself lead to fluctuations in blood sugar levels and also cause tension, anxiety, and sleep loss. Also, try and reduce caffeine intake. Caffeine can exacerbate irritability, headaches, palpitations. I wanted to just say a few special words about calcium and vitamin D. And they work together to actually maintain the healthiness of the bones, the muscles, and the teeth. And also Nick will be saying a little bit later about the possible benefits in premenstrual syndromes. So there is I put a link to the British Dietetic Association here, and there's some very useful information on there about calcium intake and how you can calculate whether your calcium intake in your diet is satisfactory. It gives information about calcium intake at different ages and calcium content of foods. Vitamin D, we get our vitamin D from certain foodstuffs, which I've listed a few there, but also from sunlight. And because there is a lack of sunlight in the UK during autumn and winter months, the government recommend a supplement of 10 micrograms a day for all adults during these seasons. And there's more information about how to take vitamin D safely on the government.uk website. I cannot overemphasize the importance of exercise and movement. Exercise not only helps with weight control, but when we exercise, we release a chemical in the brain called serotonin, and this has a positive effect on mental health. Yoga, meditation, mindfulness practices also lead to a better balance of peace and energy. Adequate sleep, also really important for mental health. For some women, it's appropriate to consider counselling, referral on to counselling. And there is a certain type of counselling called cognitive behavioural therapy, which has actually been proven to be beneficial in alleviating symptoms of premenstrual disorders. So the first port of call would usually be the GP. And I would suggest that when you approach the practice, it's a good idea to ask whether there are any GPs in the practice who have a particular interest in women's health and to book in with them. Your local sexual health service may also have doctors and nurses who have expertise in this field. But if you don't feel that you're receiving adequate help and support from the GP practice, then the next step would be to be referred through to a specialist clinic, either in the community or hospital-based. And NAPS and IAPMD, the International Association for Premenstrual Disorders, both have directories of specialists that you can access to find out where your local specialist and services are. And Nick, at the end of the talk, is going to put some links through to those websites. So I'll now pass over to Nick to talk about treatments.
Thank you very much, Kerry. I think that was a crystal clear presentation.
Thank you.
And very much appreciate that. Let me just share back the slides. So again, I hope you can all see that now. I'm going to summarize in the short time allocated what you might expect from your specialist healthcare professional if you are able to get a referral to one of our centres. But before I do that, I would like to talk a little bit about the prevalence, how common is this problem, and the potential causes, the theories that are out there. So as far as the severe type of PMS is concerned, a PMDD, it's thought to affect about 5 to 8% of the general population. But in one study, that increased to 23% in perimenopausal women, probably because of the hormone fluctuations that occur at that particular time of a woman's life. Moderate PMS, Carrie Sadler was part of a survey called the Southampton Women's Survey, where they looked at particularly contraceptive use, but they did actually look at PMS as well. And it was estimated that around 24% of women suffered with PMS in that particular population. So there are likely to be multiple etiologies, but as Carrie said, serotonin does seem to be a key neurotransmitter. So as estrogen levels drop, approaching the premenstrual phase, then this can lead to a fall in serotonin and it can induce low mood symptoms. Also, for women who are progesterone sensitive, its conversion to allopregnanolone in the second half of the cycle can have a mood suppressant effect, although some women, I have to say, do find progesterone has a calming effect and helps with their sleep. But the key is cyclicity. And one of the questions was, how do I know if I have PMS? It's if the symptoms are cyclic and particularly related to menstruation. Although some women may only have one good week during the cycle, but there is at least some respite from the symptoms. And what causes all this? It's probably a genetic predisposition. Really interesting work going on at Harvard by Peter Schmidt and David Rubinow has shown that there are differences in how the estrogen receptors are coded in PMDD sufferers compared to women not suffering with PMDD. And Professor Goldman, who led that research, said when the first publication came out, he said, this is a big moment for women's health because it establishes that women with PMDD have an intrinsic difference in their molecular apparatus for response to sex hormones. These are not just emotional behaviors that they should be able to voluntarily control. So the key really was the development of a consensus and guidelines on PMS if we were going to encourage evidence-based practice. And the first of these guidelines was published in 2007. This was on the RCOG website. It was referred to as the Green Top guideline. And then we updated this guideline in 2017, ably led by Professor Sean O'Brien. Lucy Baker did most of the hard work in terms of the literature search. Michael Craig was also on these guidelines. And Michael is a psychiatrist, although he's trained in gynecology as well. So he refers himself to himself as a gynecologist. And it's great because this condition does straddle both specialties. And please do have a look at the guidelines, which are available in their full unabridged form on the RCOG website, rcog.org.uk, and also on the PMS website. These are the abbreviated guidelines, which are perhaps a bit more digestible, which were specifically created for NAPS. So Carrie's already touched on complementary therapies, and really the problem that we have is that clinical studies are limited and underpowered. If we as doctors refer a patient to a therapist for complementary therapies, then we retain legal responsibility. So it's really important that if we are recommending them, that they are evidence-based for effectiveness and safety. And just because something is alternative doesn't mean to say that it doesn't necessarily have a side effect or interaction with other medications. So we really do need to think carefully about what that woman is using as well, and would the complementary therapy interfere with it. Now, I don't have time to go into this in any great detail, but suffice to say that these are the most evidence-based of the complementary therapies. Vitamin B6 has been found to be in some small studies of benefit, but the problem is that the larger studies have not confirmed this benefit. And when using the higher dose preparations, this can actually lead to pins and needles and other neurological side effects. So it's not really that recommended, even though many women have used that. Calcium can be of some benefit, and there have been some couple of randomized controlled trials and studies which show that women with the lowest levels of calcium perhaps have the severest symptoms. Isoflavones derived from red clover and soy can also be of benefit. There have been a couple of randomized trials with those, worth a try. Promensil is a good evidence-based one. Agnus castus, derived from the fruit of the chasteberry tree, probably the most evidence-based. 7 out of 8 randomized trials showed benefit, but the problem is that we have a lack of standardized preparations, and the dose used in some of the studies was around 20 milligrams, even though the preparations available in the UK are typically around 4 milligrams. St. John's wort can help with mood symptoms, but it can interact with almost anything. So I certainly don't recommend that unless you've consulted with your doctor first of all. Now, this is the algorithm that's in the guidelines that we use for the evidence-based management of premenstrual symptoms. In the first line, it's the pill and low-dose SSRIs. As a second line, hormone therapies. As a third line, GnRH analogs, which switch off the ovaries completely. And fourth line, total abdominal hysterectomy, and bilateral oophorectomy. So a total hysterectomy, removing the ovaries. With the analogues and with hysterectomy, very important that add-back hormone therapy is used, because we don't want to replace cycle-related symptoms with menopause symptoms. Why do SSRIs work? Well, they increase the levels of serotonin, which improves mood. And what's really exciting, I think, is that the SSRIs have been shown in a number of studies to be effective, even if just used in the second half of the cycle, or even just as the symptoms occur. They don't have to be used all the time, which means you don't develop a dependence on the SSRIs. And in my experience, one of the most effective and well-tolerated SSRIs is escitalopram. In the perimenopause, my preference is for hormone therapy rather than SSRIs, because there are often menopause symptoms associated with the cycle-related symptoms, the sort of perfect storm, if you like. Contraceptive pill, how does it work? Well, it suppresses the hormone fluctuations which cause the symptoms, and should be considered as one of the first-line pharmaceutical interventions. And my view is, if the pill is going to be used, then we should avoid using the hormone-free intervals. So pill packets should be used back-to-back, if at all possible. This chart shows how we moderate hormone fluctuations. This is in a natural menstrual cycle. This is with traditional cyclic monthly contraceptives, and this is with continuous or long cycle contraceptives that flatten the hormones that otherwise can trigger the neurotransmitters to cause symptoms. This graph essentially is showing that the two studies that were performed with a low-dose pill called Yaz, which is licensed in some countries for the treatment of PMDD, the treatment effect was very similar to that with SSRIs. So depending on the preference of the individual, you could start with a pill or start with an SSRI. There's also some research planned to look at whether there is a synergistic benefit, an added benefit, by using both the pill and the SSRI at the same time. One of the treatments that's been around for many, many years, and certainly one of the standard treatments that we use in our units at Queen Charlotte's and Chelsea and Westminster, is hormone therapy. But the dose of hormone therapy has to be high enough to suppress the hormone fluctuations, because we're not just replacing hormones, we're stabilizing hormone fluctuations. If you like, the analogy is that we're using HRT instead of the pill to stabilize those hormone fluctuations. And commonly we use these estradiol type patches, which are small and well tolerated, or estrogel. And now we even have a spray called Lenzetto, which can be used, although there's less experience of using that for PMS symptoms. When we're giving estrogen suppressing the cycle, it's important that we protect the lining of the uterus, and that's where utrogestan, natural progesterone, is used in order to induce a withdrawal bleed. And this can either be taken orally or inserted vaginally, depending on how well it's tolerated. Some women, particularly those that require contraception, might have a Mirena intrauterine system inserted, but please beware that the Mirena itself can induce PMS type side effects in those women who are very progesterone sensitive. For those women with the most severe symptoms, what we have to do sometimes is completely switch off the cycle. And this is where we use a nasal GnRH analog, such as Cinerol, or a monthly or 3-monthly injection, Zoladex. But as I said before, we don't want to replace cyclic symptoms with menopause symptoms. So it's really important that we add back hormone therapy. And typically we will add back estrogen, either gel or a patch, together with some natural progesterone. But for long-term treatment, it's important that we monitor the bone density, because if you suppress the ovaries for a very long time and you don't give add-back hormone therapy, or not an adequate amount, then potentially that could lead to osteoporosis. Now, hysterectomy and bilateral oophorectomy, when we remove the ovaries as well as the uterus, might seem like a radical solution, but many women have tried the other treatments and had some benefit, or they want a permanent solution. And that's where hysterectomy and bilateral oophorectomy in women not wanting to have children later down the line, although we mustn't forget that adoption is an option, and you know, that mustn't be underestimated. The hysterectomy has a huge benefit, I find, when it's done, and the majority of our patients do really well, but it's important that they get adequate hormone therapy, because if you don't give the hormone therapy, again, you can replace cyclic symptoms with hot flushes and sweats and other menopause symptoms. And of course, if there are fibroids or if there's endometriosis, then potentially you're dealing with other pathology at the same time. So just the key messages before we move on to Emily's talk. What to expect from your specialist healthcare professional. What I would expect, what I would want, is that there should be reference to RCOG, NAPS, and IAPMD guidance when deciding the treatment options in women with severe PMS and PMDD. There should be advice regarding evidence-based complementary therapies. There should be advice regarding cycle suppression treatments, which I've mentioned, and also psychological approaches, CBT, which Kerry has mentioned, and SSRIs. And also, we mustn't forget that hysterectomy with effective ADVAC hormone therapy may be a last resort, but it's a very effective resort and very appropriate for some women. So with that, I'm going to now stop sharing my slides, and I'm going to invite Emily to move on to her report. So Emily, we look forward to your story. Thank you very much.
Thank you both. Thank you, Nick and Carrie. It's definitely something that I wish I had been able to listen to when I was first diagnosed. So evening, everybody. So I'm Emily. I was first diagnosed with PMDD at age 26, although my problems started long before that, about 15 years before that, actually. They first started having emotional difficulty when I was age 11 and I hit puberty. However, the real problems began when I was about 13 and started my periods. Over the years, I was treated for depression, anxiety, self-harm, and eating disorders, including anorexia nervosa. I constantly felt out of control and different, and I didn't understand myself. But my eating disorder was helpful because it made me feel in control of something. At age 18, I first sought help and went under the mental health service. I had a course of cognitive behavioural therapy, which Carrie's already mentioned. However, I wasn't really ready to give up my control of my eating disorder because I still felt completely out of control. A few years passed and I went off to university. I had a course of cognitive analytical therapy with the eating disorders team. Cognitive analytical therapy works to help you find the triggers and establish healthy exits that are not self-destructive. Through cognitive analytical therapy, I learned how to eat properly again, but the triggers identified in the therapy weren't the root cause of my problems. I could reframe situations, but the difficult emotions still kept coming and they overwhelmed me. I didn't know how to manage these, and I couldn't really identify a reason why they kept coming, so I ended up relapsing. Following my relapse, I was referred for dialectical behavioural therapy, otherwise known as DBT. DBT taught me lots of strategies, such as distraction techniques and ways to calm me down. It taught me interpersonal effectiveness skills and how to engage in things like mindfulness. These were all skills which I used to try and maintain my safety when I became really distressed, a time that I now know to be PMDD rage, or when the luteal phase hit. DBT focused on the idea that emotions were like waves. They would come and go, and they fluctuated. However, this didn't seem to be true for me. When my PMDD hit and my progesterone started to rise, my negative emotions and associated urges to hurt myself just got stronger and stronger until I had a bleed. However, I was living with undiagnosed PMDD, so I struggled to understand this for myself. I wasn't aware how I experienced life was perhaps not normal. I had lived with crippling anxiety and self-destructive urges for so long, I didn't even realise how much it was impacting my life. As I got older, my PMDD seemed to get worse. However, it wasn't really that it got worse. I personally think that it was as the demands of life increased, I struggled to be the person that I wanted to be in the very limited time frame of feeling well each month. This caused my mental health to spiral out of control, with my mental health worsening during the luteal phase. My limited well days were so heavily tainted as I was overwhelmed by guilt and shame for how I had acted. I tried to repair broken relationships and catch up on my ever-growing to-do list of things that I hadn't had the energy, concentration, or motivation to do during my luteal phase. My PMDD symptoms also exacerbated my eating disorder, as I would crave sugar and sweet things during the luteal phase, which resulted in me feeling out of control. This worsened my need to do strict and engage in my anorexia and overexercise. My self-worth, self-esteem, and confidence suffered. I constantly felt like a failure. Why couldn't I be like everybody else? Why, despite all of this treatment and effort, couldn't I break the cycle of eating disorders and self-harm? Somehow I made it through university, but 3 short years after graduating, I walked away from my dream career. I just didn't know how to cope with life. My mum and a close friend had noticed a pattern. I was always at the worst right before my period, but physically my periods were fine. They were heavy, but they were painless. I considered myself lucky because as my friends got spots and painful cramps, mood swings, I literally didn't even know mine was upon me. But my friends and family did because of my mental health. I became tired, irritable, grumpy, my mood plummeted, and my anxiety skyrocketed. It was around this time each month that I went from being able to manage my mental health to needing additional input. When we first picked up on this pattern and heard of PMDD, I talked to my psychiatrist about it. However, they had little knowledge and dismissed this. I was vulnerable and lacked any sense of self-worth at the time, and I felt unable to advocate for myself. I kind of had them on a pedestal. They were the professionals and therefore the experts, so I just pushed it to one side. Fortunately, I had a really good relationship with my GP. I saw her on a regular basis, and over the years we talked about the possibility of my mental health being linked to my hormones a number of times. But I was fighting so hard just to keep going, keep my head above the water, and having been dismissed previously, the idea of really taking it seriously felt far too time-consuming and overwhelming. So I just placed it on the back burner again. And we didn't do anything about it until one week when I was in crisis. My GP asked to see me daily due to the risks that are involved in me feeling suicidal. The first day I saw her, I couldn't make eye contact. I'd had a terrible weekend. I wasn't able to speak to her, I couldn't stop shaking, and I was struggling with eating and self-destructive urges. My mum stayed with me over the weekend and the next few days. The next time I saw my GP, I was okay again. She asked what had changed. There was only one thing. I'd come on my period. Luckily, I tracked my cycle on the calendar, and as part of my mental health treatment, I kept a reflective journal each day. So we were able to marry the two together and use this as cycle tracking. I still wasn't fully on board with the diagnosis. However, I'd exhausted all other avenues and I felt hopeless, so I figured that I'd got nothing to lose. I was referred to gynecology, started on estrogen treatment, and I noticed huge improvements in my mood. It was honestly the best drug that I'd ever taken over all the psychiatric drugs I'd had. However, I was informed that I couldn't use unopposed estrogen long term due to the risks to my endometrium and uterus. So after a few weeks, I had the Mirena coil fitted. This was the start of a number of weeks of feeling suicidal. I understood by this point that my hormone fluctuations were part of what would cause my PMDD. And I was like, I'll just carry on with it. I'll carry on with it. However, my gynecologist advised that this was removed, so that was what happened. I tried After this, I tried numerous different preparations, doses, and durations of cyclical progesterone to try and act as my protective progesterone. However, each time I had the progesterone, I became suicidal and completely unable to manage my mental health within 36 hours of taking the first dose. However, I understood that it was important that I continue to take the progesterone to protect my uterus. This was when I learned that I had progesterone intolerance. My diagnosis of progesterone intolerance and PMDD helped me better understand myself and my struggles. However, I felt like there was a big disconnect between my mental health team and my gynecology team, and this was quite difficult to manage. I worked really closely with my mental health team to educate them about PMDD and how it affected me, and also to educate them that not taking progesterone really wasn't an option. Following this, I took the GnRH analog, which Nick spoke about, which put me into the chemical menopause. This was good initially, but then it began to fail, and I started having periods again outside of taking the ADVAT progesterone. So I was changed to the Zoladex. Again, it was good to begin with. I trialed what my consultant called a progesterone holiday. This was where I took estrogen whilst in chemical menopause without any ADVAT progesterone. It was the best 3 months of my life. However, I learned that I couldn't do this long term due to the risks associated with the unopposed estrogen. So I had to go back to taking the cyclical progesterone again. For me, HRT and then HRT in the chemical menopause widened the gap. It made the good times better, but it made the bad times so much worse. As time went on, the Zoladex then began to fail, and I was needing to have the injections more and more frequently. So I decided to opt for surgery. It was a long process. I was only 28 at the time, and I had no children, but the doctors needed to ensure that I was making the correct decision for me personally, that I wasn't making this in haste or without understanding all the implications that might follow. There were also some concerns raised that my mental health issues would remain and that I may have unrealistic expectations of what surgery might bring me. However, through a lot of multidisciplinary team working, I requested that this decision be taken to be made by the MDT of the clinicians where I was a patient, and eventually I was consented and listed for surgery. I was fortunate enough to be able to receive funding to have my eggs collected on the NHS because I was having my uterus and womb and everything removed in order to protect my life, because that's how extreme things had become for me. However, the egg harvesting and IVF created a lot of hormone fluctuation, and it meant that I needed to come out of the chemical menopause. Also, following there was a surge in progesterone, which meant that it was really not an easy process to go through, but I'm really glad I did it. In May 2019, age 29, I had a total hysterectomy with bilateral Safran-Grew oophorectomy and ovarian cortex cryopreservation. Since my surgery, I've not self-harmed. I consider myself to be in a stable place within my eating disorder recovery, and I've had no further self-destruction. I don't have a CPM, and I have no contact with the mental health services. But I think it's important to remember that although surgery is the final stage treatment, it's not a magic fix. It stops the natural process of the menstrual cycle, but it doesn't stop the brain sensitivities to the hormone fluctuations. Getting my HRT right has been a real challenge and struggle at times. And each time my HRT has changed, the fluctuations still cause symptoms. Albeit, for me, with the progesterone out of the equation, the symptoms are not so bad and they've become much more manageable. I have still experienced something that I've heard referred to as ghost cycling or phantom cycling. I didn't want to track initially, but I found that it does happen for me. The biggest change since my surgery is that I feel in control of my life. It's been really important for me to relearn my emotions and the responses to my emotions, and to learn that I can experience a difficult emotion and it will go away. it won't just carry on until I become out of control. Post-op, I've been through a bit of a process. I class the first year of post-op as the honeymoon period. The year that I got the surgery, I went through physical recovery and experienced lots of firsts. My first Christmas, my first birthday. I worked on repairing relationships with friends and family and enjoyed occasions. And I even managed to go back to work and get a job. However, following that, when life became a bit more stable and I guess normal, I started to go through the grief cycle. I'd spent so long just trying to survive that post-op, I began to grieve all the years I'd lost, all the missed opportunities and everything that I hadn't been able to attain that my friends had. And then, of course, the big one, I started to grieve my fertility. But despite all this, I don't regret my surgery. I have my life, and although it's not perfect, I don't regret surgery, as I honestly don't believe I'd be able to sit here and talk to you today had surgery not been an option for me. Thank you.
Emily, thank you very much. And I think one of the comments from the delegates summed it up, that we think you're a superstar for the work that you do, and you know, it's difficult telling your story, isn't it? And but it's so important that people realize, you know, the pathway that you've taken and that you've come out at the end of it. And thank you very much for the work you do. I'd now like to go on to the panel discussion. We have had some additional questions, as well as the many that we've received already. So as I say, we'll try and work our way through them as much as possible. And I hope some of them have been answered by our talks already. Perhaps I could start with Carrie, I'll give you a bit of a break, Emily, and ask you about what happens to PMS in the perimenopause and how we should best be managing that.
I think I'll just go back a stage just to perhaps look at a broader picture and bring in what we sort of call the triad of conditions. So basically, going back to basics again, we think PMS happens, I think I'm simplifying things here, but happens because of cyclical changes in the menstrual cycle. So that's why women get a very welcome relief during pregnancy, because the cycle is suppressed because of the pregnancy. But there do seem to be stages in a woman's reproductive life when PMS symptoms can, well, cycle-related mood disorders can actually worsen due to hormonal fluctuations. And one of those is postnatally, and it seems to be premenstrual syndrome seem to be linked in with postnatal depression, and also around the time of the perimenopause. So just going back a stage to explain that the menopause is when a woman's periods stop. The perimenopause, and the average age for that is sort of early 50s, 50, 52. Leading up to that, a woman's cycle can often become more irregular, and that's due to a reduction in frequency of a woman ovulating. And so she has the sort of cyclical change, but it becomes a little bit more erratic. And that in some women seems to exacerbate cyclical mood problems. For most women, when their periods stop, because by definition that's when your cycle stops, they will actually get relief in their PMS. So that's the good news, that most women will actually improve significantly after the menopause. I think the approach to treatment at any stage, we're not going to concentrate on postnatal depression here, but it is the same, that it's about fully assessing the woman and looking at all the factors we've talked about, and then deciding with the woman, her making an informed choice about whether she wants to start with complementary therapies or antidepressant medication, which I think we've said at one point with PMS-like symptoms, it does work equally well just to take the antidepressant in the second half of the cycle under the supervision of your healthcare professional, or hormonal treatment. And one of the positives about treating premenstrual disorders in the perimenopause is that one of the treatment options is hormone replacement therapy. So estrogen, inadequate doses, and progestogen. And I'll just finish by, I've just picked up a couple of questions which link into this, that link into it and can be answered quite quickly, in that somebody's asked about estrogen and migraine. So the preparations that are used in PMS and around the time of the menopause, estrogen preparations in hormone replacement therapy, are natural estrogens. So it's possible to use those even if a woman suffers with migraine. Whereas the use of a combined oral hormonal contraceptive, it can be a problem with migraine. And indeed, perimenopausally, migraines can actually be because of lack of estrogen. So it is all a bit complex, but I just wanted to say that just because you have migraines perhaps with the hormonal contraceptive doesn't mean to say that you wouldn't be eligible for a different type of estrogen in that context. And the other thing we've talked, I'll just finish off by saying we've talked about progestogens quite a bit, but there are lots of different types of progestogens. So just because you're progesterone intolerant doesn't mean to say different ones can be tried. And somebody's mentioned a preparation called crinone, which is a vaginal progesterone, which can sometimes be better tolerated than other progestogens. So I'll hand over to Nick, who's more of an expert on this than me.
Well, just to follow on from that, crinone's an option, cyclogest, which is another form of vaginal progesterone, lower dose intrauterine systems. So Mirena, there is one called JDS, another one called Kylena. They're not currently licensed for protecting the lining of the womb when used with estrogen therapy, but are giving us options for women who are progesterone intolerant. Emily, there's a question on how should one go about revealing one's PMDD diagnosis? Clearly, for some people, it's difficult for them to talk about it. How did you feel when you first had to approach somebody about it?
So I think initially I didn't reveal it to anybody, even though I was very open about my mental health. I didn't know how people would sort of receive the fact that I was then talking about what I saw to be just another condition at the time. I didn't relate it at that time. I hadn't connected that all my problems were actually as a result of PMDD. So I guess the best way that I often approached telling people was that I would sort of try and print off some basic information for them, like if it's friends or family, try and direct them to some of the easier to read literature. So explaining what it is and how it affected me personally, because there's lots to say about, like Carrie said, there's over 200 symptoms that could be, but I tried to keep it close to me personally. What helped me, what were my main symptoms and what helped me. And I think for me, I found that when I educated people about it and they understood it more, then they were able to support me more through it, which in turn then made it easier for me to get through the difficult weeks. So yeah, I'd just get yourself informed, and unfortunately you have to be your own advocate because there is not the awareness is improving, but at the moment it's still limited, especially within the mental health sector. But it has definitely come on a lot, even in the last few years that I've been suffering with PMDD and trying to raise education in the sector.
Yeah, absolutely. It's about removing that stigma, isn't it? To so people don't hesitate to approach their GPs and gynecologists and psychiatrists. And I think that's one of the challenges, that people are not infrequently diagnosed with perhaps bipolar disorder, where the cyclicity of symptoms is missed. And this can go on, I saw one question for 20 years, and eventually the diagnosis is made. And then it's met with a feeling of relief, but also remorse for the years, to grief for the years that have been lost, when the people have been given the wrong diagnosis. I
think another diagnosis that I've noticed was one that I received myself and was then superseded by PMDD, is the diagnosis of traits of emotionally unstable personality disorder, or if you're in the US, borderline personality disorder, because to the outsider it's like you're just being impulsive and that there's no rationale for it. Whereas obviously I then learned that every time I was getting to that stage of self-harm and feeling suicidal, it was all linked to my menstrual cycle and the increase in progesterone. So I think there's a lot of misdiagnosis of that as well, probably.
Can I just say that I hope that now that there are more sort of apps where you can record symptoms, that will be attractive to our younger age group, and so hopefully the people won't be misdiagnosed or misdiagnosed less, because I think when we did our peer support group, or your peer support group that I came along to, Emily, so many people, it was a recurring theme, wasn't it, that women had missed out on years of their life. That came across very strongly. So I think to make the diagnosis for the population to be aware, and then the health services to be more aware, including the mental health services.
Definitely.
And prospective documenting of symptoms is so important, isn't it? Because it's the cyclicity can otherwise be missed. So many questions. Another one here about PMS in the workplace and how you should approach your managers at work, colleagues, etc., to cut you some slack, for instance, at a time of the month that's difficult for you, and give you some space. And I don't know whether Emily or Carrie, you want to comment on that at all.
I know because of obviously everything that I've been through, when I went into my new workplace after post-op, I actually had an article coming out in Cosmopolitan about 2 months after I started, and I was like, oh, awkward. So I was just very open with them, and I'm lucky that I work in a team where it's periods, and in healthcare lots of things are just spoken about very openly. But something that I was always told, I guess, was just to be honest, and I think that was like the best thing for me, to just be honest with my employers and tell them that there might be times where I might need to perhaps work a little bit more flexibly, or perhaps not be clinical. But yeah, I think the best thing was sort of having that honest conversation that it is a registered illness. It's if you're experiencing significant symptoms for over 6 months, it can be classed as a disability. So therefore you are protected by the Disability Act and Equal Opportunities. And so yeah, maybe even worth seeing if you can get any support from occupational health, but just get yourself informed, I think. And again, just be your own advocate. And I know a lot of people, including myself, end up not being able to work when they're really struggling with their PMDD, and it feels like it's not being managed properly. And so lots of people tend to perhaps go self-employed, which I know is not always the easiest thing to do, but it gives you that flexibility to perhaps work more when you're feeling well, and just take a week off when you know it's going to be your really bad week, when you have your luteal phase or need to take progesterone.
One of the questions that's been asked is about hormone tests, and I think I'd like to emphasize that There isn't a hormone test which will diagnose this condition, and often hormone test results are normal, and it's more how the body responds to the normal fluctuations in hormone levels in those with a vulnerability to those hormonal changes rather than the actual hormone levels, which are the problem. Although we do see a link with PCOS, for instance, in women who have PCOS and are ovulating, and there may be a common genetic sort of origin for that. We also know that there may be a link to some types of contraceptives, for instance, where people are hormone sensitive and they're given the mini pill or the implant or the Mirena, and they react adversely to the synthetic progesterone within those preparations. Just going through this, there was a lady here that had a hysterectomy but had the ovaries preserved, and of course then the cycle-related symptoms continued in the absence of menstruation. And if a hysterectomy is to be performed, then it does need to be with the ovaries removed. Another option would be just to have the ovaries removed, but then you still need to protect the womb lining. And so women with PMS, often progesterone intolerant, will potentially get PMS type side effects when HRT is added back. Carrie, there's a question about those women with PMS, but also wanting to start a family. How would you approach that individual?
I think it really needs to be approached on an individual basis about how and weighing up the different treatment options in that situation and the severity of the premenstrual syndrome or PMDD, and when the woman wants to start her family. So bringing it together, obviously some of the treatments we've talked about are contraceptive, so that's not ideal for a woman who actually wants to get pregnant. With respect to the SSRIs, the group of antidepressants we've talked about as being a treatment in PMS, there are some studies to suggest that there may be a small risk of congenital abnormalities, although the studies were not completely robust in that it may have been other factors that led to those problems. So as I said at the beginning, it's about weighing up the risks and the benefits. And obviously, if you decide to use an SSRI, there are some that are safer than others in pregnancy. Correct me if I'm wrong, Nick, but I think Michael Craig, who is the gynae psychiatrist that we were talking about, favours fluoxetine and sertraline. Is that? Am I right on that?
In association with pregnancy, yes,
yes,
because they're more tried and tested.
Yes. But, you would advise a woman that as soon as she found out she was pregnant to stop it, because as I said when I was talking earlier, when you become pregnant, then your symptoms should resolve anyway. I don't know about the safety of complementaries like Agnus castus in pregnancy.
No evidence, that's the problem.
Yeah.
I mean, we're not aware of any problem.
Yes, but, it's a sort of lack of evidence rather than
of
being.
There's not evidence of absence.
Yeah, yes, that's right. So there are a number of considerations. So a woman in that situation may prefer to concentrate on sort of lifestyle measures to start off with. But if the symptoms are severe, then maybe consider another treatment. Obviously, wouldn't want a contraceptive.
No, I agree. I think an SSRI is a reasonably good option, particularly in the luteal phase. And as you said, can potentially be continued, although an attempt to come off should be made. And important also to emphasize that pregnancy itself is actually a good treatment for cycle-related symptoms. But watch out for postnatal depression, blues and depression, which potentially is worse. It affects people with PMS, PMDD worse. And so we often arrange a follow-up shortly after delivery, where sometimes we will even treat in the postnatal phase, postnatal period, with hormone therapy. Once people ask, well, is that a problem with breastfeeding? No, it's not. Once the breast milk is done, it doesn't suppress it, it doesn't harm the baby, as long as you use the natural hormones. One of the questions that's been asked about HRT is the use of testosterone to optimize energy and libido. That is something that we do counsel our patients to have on a fairly regular basis if there is an issue with, sexual desire and arousal, which usually doesn't happen so much with the natural hormone therapy, but can actually happen more with the contraceptive pill, can't it, Carrie? Because that increases the level of the protein, SHBG, that binds testosterone. Sometimes we even have to add back a little bit of testosterone in women on the pill.
I think sorry, Nick, can I just
off license or off label?
Yes, and I think it's important to not to explore other reasons for loss of sexual desire as well, sort of the hormones, because it's not a physiological cause.
Absolutely, there needs to be a full counselling discussion about the relationship and about other aspects, social aspects, as well as discussion of hormonal aspects.
And perimenopausally, it can sort of vaginal dryness can often be due to estrogen deficiency. So to use local vaginal estrogen can be extremely effective and is very easily obtained for. Well, that is something that a GP would be very happy to prescribe.
So I'm mindful of the time, but I think we've got time for a couple more questions. There's a question here. Emily, is there a link between PMS and eating disorders?
Am I not on mute? So I have looked into the research and things when I was ill myself, and because I've been asked this a number of times. There is a study by, I think it's called by Klump, to say that there is some research between bulimia and eating disorders. Anecdotally, I personally would say yes. I know quite a few people that struggle with eating disorders and have later discovered that they've got a sort of PMDD or severe PMS. I think what strikes me as the most likely sort of anecdotally thing is that at low weights, obviously your menstrual cycle can be suppressed because you're not producing the hormones to enable you to get pregnant. And also then obviously in the luteal phase, when people can really struggle with their emotions and cravings for sweet foods, can quite often lead to a binge purge bulimia type situation and cycle. So they're sort of anecdotally what I've noticed with a lot of peer support work, both in eating disorders and in PMS and PMDD.
Yeah. It's that premenstrual exacerbation, isn't it, where there may be a background eating disorder, but it gets acutely worse premenstrually as well. In fact, that sort of brings to mind one of the things which we always try to emphasize, that where we think it's PME rather than pure PMDD or PMS, where the symptoms resolve completely, we're very clear that with cycle suppression treatments, we're not potentially going to influence the background problems, but it's more reducing the impact that the premenstrual phase can have on those symptoms. One of the questions that has been asked quite a lot is research, and we are doing research into PMS, PMDD. A study recently, which unfortunately didn't end up showing a benefit of active treatment over placebo, was a study called sepranolone, which is a GABA receptor modulator. And it wasn't that the active treatment didn't show benefit, it's just that the placebo works so well that it was difficult to see a difference between the two. But we're hoping that in the future, further similar studies such as that will continue. And also the genetic studies, which I've mentioned. And also we hope to do more treatment with hormone cycle suppression. And perhaps looking also at modern pills as well. And I think it is frustrating that in the UK that there aren't licensed treatment options for treating PMS, PMDD. And so that's one of the things perhaps that dissuades primary and secondary care for in terms of prescribing treatments for women with this problem. So I think that's really all the time that we're going to have to be able to address the questions this evening, but we are planning our next webinar already to try and have it as a Q&A webinar. We can mop up as many of the questions that have been asked tonight and we've not been able to address. And if you have enjoyed this webinar, and either as a sufferer or as a healthcare professional would like to join us in NAPS, then please do join. It will make it easy for you to access specialist information, advice, and assistance. We've got Ask the Expert, which I know many people find helpful. It will help us to support vital work on behalf of the PMS community. The website is at pms.org.uk, and we've recently revamped it. It's a completely new website, so hopefully you will find it useful and easy to navigate. This shows the memberships, which hopefully are not too onerous, 25 per annum, just under 50p per week. For standard concessionary, 12.50, just under 30 per week, and £50 per annum for professional members. And also, just to finish on Hormone Health, which is a group of doctors which I've been collaborating with, providing a private service for hormone-related problems. So in addition to our NHS clinics at Queen Charlotte's and Chelsea and Westminster, we are trying to bring evidence-based practice into the private sector as well. So with that, I would like to say a huge thank you to my panelists, Carrie Sadler and Emily Elson, for their wonderful presentations. I'd like to also thank Jodie Newton from Designated, who worked extremely hard for us to be able to bring this webinar to you this evening. And I'd like to finish on a little thank you also for our CEO, Jackie Howe, without whom NAPS wouldn't have been able to continue. Thank you for all the fabulous work that you do for PMS and for NAPS. So with that, I'd like to thank all the delegates, and we look forward to seeing you at our next webinar.